Pradeep Nimade was to present this. However, he has some technical difficulties with his computer, and therefore I would be giving this talk. Role of external fixation and internal fixation in open fractures. We all know that stabilization plays a very major role in early recovery of patients with open fractures. And the problem is when to do internal, when to do external, and when to change over from external to internal. Now I'll start with a case. This young man had an open shaft femur fracture, presented at 42, about 2 to 3 days after the accident. You can see there is a wound here, a small bony piece. This fragment had come out of that. And when he came in, there was already a purulent discharge from this wound. Patient was febrile, and the first thing, of course, I did was an extensive debridement. As you can see here, the muscles were necrotic, subcutaneous tissue was necrotic, and this is at the end of my procedure. Since there was already presence of pus, I decided to do an external fixator, and as you can see, I have got a very good reduction. I have done VAC dressing, and this is him at about 12 days. Now what should I do? Should I continue with external fixator? Because I'm really scared that if I change over to internal fixation, then chances of, I felt that the chances of infection would be high. Now I'll just stop sharing, and can I have a discussion on this topic, whether you would like to change over or you would like to continue. Tanna sir, what would be your choice? Followed by Dr. Sanjeev Gaur. Tanna sir, you are there? No, he's not there. Dr. Sanjeev Gaur, what would you suggest?
I think with in the presence of the infection, how much days now since the fixator has been put in?
It's about 10th day. I have a
will
good cover, but when he came in, there was a distinct pus there.
Yeah, we have to currently assess the situation, but I would rather, since the reduction is so nice and it is held with a good fixator, I will hold on for some more time.
Okay. Any other opinion? Any other opinion? Dr. Shivshankar, you are there? Dr. Sen, you there? No, I think there are too many conferences going on. So I'll just, yes, please. Dr. Shivshankar, you are there?
Yes.
Yeah.
Yeah. Can you hear me?
Yes, we can.
Okay. See, now it is only about 10 to 12 days. So it's a right time for me to change over to internal fixation. If I cannot do within 21 days, then I'll continue with the fixator or change the modality to something else. So either do it within the about ideal period is around 2 weeks, where I can change if the wound is good from external fixator to internal fixation. Thank you, Vikas.
Dr. Deen Dayan, your last word, and then we go ahead.
Yeah, but always it depends on the way it was contaminated, or the amount of pus that you see on the day one determines it. But I think if it was definitely purulent and then you had to debride a lot and then soft tissues were damaged, because you have got a good reduction, circumferential reduction is there. Majority of the times when you have a circumferential reduction like this, often it goes on to heal with the external fixator. So I think we can maintain the external fixator. The only reason is it was infected in the beginning.
Correct. So I continued with the fixator. This is him at 2 months. I dynamized the fixator. 4 months, I'm still not happy at all with the callus. 5 months, the patient was really getting fed up. There was some callus, So I took out the fixator and he came back with severe pain. Now what do I do? There are no signs of infection. In fact, I got an MRI done which ruled out infection.
No, consecutive X-rays, it doesn't show healing, and then infection is not there clinically, no signs of infection. Then it is the right time to change for internal fixation. So probably with the second consecutive follow-up, you could have done that. Yes.
I totally agree with you. In hindsight, I mean, this is classic case. What could have been done differently? Either I could have put in a bone graft or I could have possibly changed over to internal fixation. So I waited for the pin tracks to settle. Generally, in such a situation, I would not like to change over to internal fixation immediately. Wait for about 3 weeks till the pin tracks healed. And then I did a lock nailing. This is him at 6 weeks. This is at 4 months. That's the range of movement. I did release the quadriceps because otherwise it was just adherent to the fracture site. This is at 4 months. This is at 6 months, healed well. And this is at 2 years. So friends, external fixator came in as an excellent tool for very good debridement. It gave us a very simple and quick stabilization in polytrauma, unstable patients, bad wounds, etc. It taught us how to do very good debridement with minimal chances of infection. Having said this, if you continue it for a long time, chances of pin tract infection are high. Now that there are many local flaps available, there is a poor access to local flaps. It is inconvenient to the patients, and chances of delayed and non-union and malunion are high. So it is generally a temporary bridge to tide over crisis. But as said by Dr. Sanjeev Gaur as well as Dr. Deen Dayal, since initially there was pus, it was too risky to shift over to internal fixation at that time. I should have possibly done a bone grafting at 2 or 3 months, possibly. But otherwise, it is always better to change over to internal fixation by about 5 or 7 days. Then there are least chances of infection. But if one has to continue with external fixation, then what I generally do is avoid a single rod system. If the system is like this, a single rod, then it is very difficult to oppose bone ends. Use a rod to rod system like this, then you can actually shove in bone fragments into one another, and then you could have a good reduction. Especially in humerus, where this length doesn't matter, or even in femur in certain situations. The first and foremost, one has to understand that the body segments are of two types. These are concentric segments where bone is covered from all sides by muscles and there is no safe corridor, plus chances of pin tract infection are very high. In that case, it is best to change over to internal fixation as early as possible. While in tibia and ulna, these are eccentric segments. There is at least one subcutaneous surface or border, and then external fixation can be continued till fracture healing. But if at all we have to do that, think of improving the bone-to-bone stability either by a cortical mismatch like this, doing a non-anatomical but stable reduction, shove bone fragment into one another, or early bone grafting. As I said, try and put one fragment into another. As you can see here, the fixator is not giving much stability. The bone does not have a stable reduction. So in that case, once the wound improves, you can put the bone piece into one another, gives a bone-to-bone docking into one another, and that improves the stability significantly like this. And that is, you can see the fragment has gone in. This is started healing well, and this is at 3.5 years. So then the chances of non and or delayed or non-union are hardly any. However, if you have a good wound, then it is best to do an internal fixation like this. There is no contamination. In this case was a little different case. You can see in just 6 hours time, the swelling had increased tremendously. That is because this fibula piece had perforated a small, perforated a artery, and he was bleeding profusely. So we had to open the fibula also. And since the wound was good, we could put in a primary internal fixation, and this is at healing. Sometimes the injury is so severe that you need internal fixation at all cost. For example, here, the case that was shown by Dr. Sagar, this is a case that was managed by Dr. Sanjay Agarwala and myself. You can see the fracture is in several pieces, and he had a compartment syndrome also. He had a badly contaminated ulna and a huge swelling here. So we had to do such an aggressive debridement that we could do an internal fixation, because with external fixation, we thought we will not get any stability. So we just excised all the wound. We just excised this piece of ulna, correspondingly excise the radius at a later time. So you can see the incision that was taken for ulna, excising the previous incision and the wound. So this was at the end of debridement and plating of the ulna. When we did that, we went ahead and did a compartment release, shortened the radius also, and fixed the radius. We could close the ulnar wound. We had a good soft tissue cover for radial wound. Sensations recovered in 24 hours. The muscles started working except flexor pollicis longus by 10th day. And this is him at 6 weeks. And this is him completely healed fracture at 4 months. And that's the function. So the prerequisites for internal fixation are an absolutely clean wound. You should be really happy about your debridement, and you should be able to obtain a good soft tissue cover over fracture site as well as implant immediately, or at the most in about 2 days time. Then only it's worthwhile doing a primary internal fixation. There are several advantages of primary internal fixation. Of course, there are several disadvantages of primary internal fixation, because if the debridement is not appropriate, then chances of infection would be very, very high. So finally, what decides whether you will do an internal or external fixation to a large extent depends on your debridement and your cover. Remember, friends, external fixator helped us to do aggressive debridement, but over a period of time, we realized that the downside of external fixation and open wound, keeping the wound open, are significant. And that is why world over, people are going to primary internal fixation and immediate or early wound cover. Thank you, friends.